الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين وعلى آله وصحبه أجمعين. Nutrition First Lecture by Professor Mahmoud Hani Sulaiman. This world map shows the percentage of under 5s suffering from underweight. As you see, the percentage in Egypt is less than 10, and the percentage is different from country to another country. This slide shows the interaction of food, nutrition, and body as an example of environment, agent, and host. The food through production, distribution, hygiene, preparation, food labels, and meals. Nutrition through carbohydrates, proteins, fats, vitamins, and minerals. Body through genetics, physiology, lifestyle, and needs. All these together interact and give the individual his health or bad health. This table shows dietary components considered essential for human health. Either energy sources as carbohydrate, fat, protein, essential amino acids, essential fatty acids, vitamins, either water soluble or fat soluble, minerals, trace elements, fiber, and water. All these together are essential for human health. Must be present in the food of humans. This is the food pyramid, shows what to eat. At base, what we must eat adequately: cereals about 400 grams, pulses about 100 grams. Then eat liberally: vegetables 250 grams, fruits 250 grams. Eat moderately: sugar about 100 grams maximum. Less is better. Eat less: salt not exceed 6 grams per day, fats not exceed 30 grams per day. This shows dietary reference intake, definitions, and use. Recommended dietary allowance, adequate intake, upper intake level, estimated average required. Recommended dietary allowance: average daily dietary intake level sufficient to meet the nutrient requirement of nearly all healthy individuals in a group. Adequate intake: estimate of RDA based on observed or experimentally determined approximations of nutrient intake by a group of healthy people. Upper intake level: highest level of daily nutrient intake likely to pose no risk of adverse health effects to almost all individuals in the general population. Estimated average requirement: nutrient intake value estimated to meet the requirement of half of the healthy individuals in a group. What is a healthy diet? Fulfills energy needs, macronutrients, provides sufficient amounts of essential nutrients, micronutrients, reduce risk of disease, is safe to consume, low contaminants or no contaminants or potentially harmful added substances. Survey for the elements for nutritional status evaluation. Nutritional status evaluation. First, nutritional history through dietary intake. Food record: these are the methods we calculate the dietary intake. Food record, 24 recall, food frequency, diet history, use of supplements, eating habits. Continued nutritional evaluation. Signs of undernutrition: low weight for height, recent weight loss, clinical signs of malnutrition, chronic or acute conditions, medication use, substance abuse. Continuous survey, related social factors, income, education, ethnicity, food assistance, medications, activity levels. Continued survey elements, chronic disease risk factors as overweight, elevated blood glucose, high blood pressure, high blood cholesterol, waist-hip ratio. Continued survey elements, body measures, height, weight, skin folds, waist circumference, hip circumference. Continued survey elements, lab tests, hemoglobin, hematocrit, iron and iron binding, serum vitamins and minerals, blood glucose, blood cholesterol, lipoproteins, C-reactive protein. Here is the data elements for community nutrition assessment. We mentioned nutritional status indicators in previous slides. Then the other data elements, community descriptors, population descriptors, health status indicators, food and nutrition resources. Some nutritional problems. Obesity. Obesity is one of the commonest expressions of unhealthy diet, often combined with decrease of physical activity. There is an epidemic of obesity. Over past 20 years, dramatic increase in prevalence of obesity all over the world. WHO said that more than 1 billion adults are overweight and 300 million are obese. Highest increase in countries with fast-growing economies, especially of Southeast Asia. 250 million in third world suffering from obesity. This table shows proportion of adults aged 15 to 59 years who are overweight or obese in Egypt. As you see on your right side, among males about 60%, among females about 76%. Epidemiological determinants of obesity. Obesogenic environment today, shared environmental, affluent lifestyle, rich food, sedentary environment leading to obesity. This environment and dietary habits play an important role. Increase income and being able to spend more on food, stress, sedentary lifestyle, and increased TV viewing. So he's sitting, non-traditional foods, fast food, junk food, aggressive advertising and marketing. Continued epidemiological determinants of obesity, age, gender and ethnicity. Age, incidence of obesity increase with age till 60 years. Vulnerability is maximum in middle age around 40 years due to hormonal changes, affluence, and increased sedentary lifestyle. Gender, females are more likely to be obese as compared to males due to inherent hormonal differences. Ethnicity, there are large unexplained variations in prevalence of obesity in different ethnic groups. Continued determinants of obesity. Education level. In Egypt, educated are in a better state of health as they are more aware and concerned about health issues. In other countries, those with a higher education level are more likely to be obese due to they are likely to be more affluent, spend more money on foods. Income, marital status, parity, smoking, physical activity all lead to obesity. Alcohol provides 7 kilocalories per gram, which is almost double calorie content of carbohydrate or proteins. Quantifying obesity. Body mass index equals weight in kilogram divided by height in meter squared. Weight in kilogram divided by height in meter squared. On your left side is the grades of obesity based on body mass index. It is either underweight, healthy or normal weight, pre-obese, overweight, obesity class 1, 2, and 3. On your right side is grades of obesity for Asians. It is some way different. Please print and use for your patients in your clinic. Obesity hazards, metabolic and degenerative. Diabetes 2, 50 to 100 times more common in obese. Diabetes 2 more common in obese. Hyperlipidemia more. All we will mention are more in obese patients. Ischemic heart disease, increased blood pressure, stroke, gallstones, breast and colon cancer, infertility, gout, polycystic ovary, more often in obese. Osteoarthritis, chronic back pain, respiratory problems, limited mobility, higher accidents, sleep apnea, and skin problems. Depression, low self-esteem, social isolation, poor employment status, impaired relationships. Life expectancy and obesity. Obesity shortens life expectancy by at least several years. The combination of obesity with smoking is particularly costly, 13 years of life. Obesity and smoking reduce life expectancy by 13 years. How might obesity shorten lifespan? Because obesity is related to coronary heart disease, cancer, accidents, stroke, COPD, diabetes, pneumonia, and suicide. Body mass index and relative risk of type 2 diabetes. As you see from this slide, that increase in weight lead to increase in diabetes prevalence. Obesity and cancer. In a study of 750,000 men and women followed for 12 years, the following was observed. Men cancer mortality ratio for those 40% or more overweight is 1.3 times in normal people. Colorectal cancer 1.7 and prostate cancer. Women cancer mortality ratio for those 40% or more overweight is 1.6. Endometrial 5.4. Gallbladder, cervical, ovarian, and postmenopausal breast cancers. All these types of cancers are increased in obese patients. Cost of obesity. Obesity and inactivity are estimated to lead to 300,000 US deaths annually. 1 year direct and indirect costs are estimated to be 117 billion. This represents 9% of all US health care costs. Classification of obesity. There are many types of cause of obesity, either neuroendocrine, iatrogenic, nutritional imbalance, physical inactivity, genetic, dysmorphic. Please type this and use it for your patients while examine your patients at your clinic to investigate the cause of their obesity. Treatment of obesity: lifestyle modification, diet, physical activity, behavior modification, and pharmacotherapy. If it is gross obesity, surgery is a must. Obesity prevention. Losing 10 kg is associated with reduction in total mortality, reduction in systolic blood pressure, reduction in diastolic blood pressure, reduction in fasting glucose, reduction in total cholesterol, beneficial rise of 8% of HDL cholesterol, improved self-esteem. Some tips on dieting. Do not skip meals to reduce weight. Do not eat leftover food. Eat many small but measured meals, or eat a minimum of 3 meals. Do not snack while watching TV. It is a myth that some foods can burn fat. Do not shop when hungry. Reduce stress through relaxation like meditation. develop a positive attitude and cheerful, exercise regularly, slow and steady weight loss of about 1 kilogram per week is safest. Food labels claiming low fat or no fat may still have a lot of calories. Food labels claiming zero cholesterol may not mean zero oil. Drink enough water each day. Alcohol has a high calorie content. Fruits and vegetables are low calorie and source of antioxidants. And Alhamdulillah, wa thank you for your good listening.